must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Yeah, and guys, something that I've heard in the past, I know that other clinicians have kind of brought this up, is that sometimes when patients have compression garments on, they report them not feeling comfortable at all and they don't want to wear them. So assuming, of course, that this patient is appropriate for compression garments, how do you guys manage that and problem solve to make the appropriate modifications to make sure that the garment was sized and at the right amounts for that particular patient?
I think that there's a correct compression garment for everybody. It's just a matter of finding the correct, compression garment for that person. Many times people would lean towards pre-manufactured, like ready-to-wear compression garments. That's not always the optimal compression garment for that patient. And sometimes that can really be a big difference. If you want to save money and you're going to a prefabricated compression garment, of course, it will never be as adequate and never be fitting as well as a custom-made compression garment for the patient. I think it depends again on the diagnosis of the patient. It depends on the shape of their limb. It depends on a lot of different variables, and oftentimes the tendency is to go with something that's already pre-manufactured, and that may or may not be the right thing for that patient. You can try it. You can go to a ready-to-wear garment. If it doesn't fit well because the size is such that it doesn't fit that person, there's yet another brand that patients might be using. So there's a large variety of ready-to-wear garments, but at one point or another, if the garment is not doing what it's supposed to do, that is containing the swelling, if the garment is uncomfortable, or the patient has donning issues, sometimes you need to then make that appropriate switch and go to a custom garment. Even though it costs more, it is more appropriate for that person who has, if you will, failed the trial of a ready-to-wear garment. That's kind of like an approach that we would take. And then there's clearly patients whose limbs are so disproportionate, where the ankle may be very skinny and the calf may be very large, or the thigh may be extremely large in comparison to the lower leg. And those patients should go into a custom compression garment right away to save them from the agony of, those inappropriate trials. Does that make sense?
Yeah, I completely agree. And just some specific questions to build on that I ask patients. Well, first, I always look at them in the garment. So to make sure to see, so I can see how it's fitting them, and whatever problems they are experiencing, I can actually visualize it myself. And I asked them if they were fitted by a certified fitter. That's important because a lot of times, especially in regards to these off-the-shelf garments that Guenter is explaining about, if the patient wears a size large pants, like they're going to go buy a size large compression sock at CVS, and that doesn't really work. And because it has to be, even the off-the-shelf garments have to be fitted for the patient, utilizing the smallest part of the ankle and the largest part of the calf, and then sizing it based on the sizing chart for that specific garment. So it's not as simple as just sort of picking something off the shelf. and they really should be fitted for it. I ask if they wear it every day, if they've washed it. Sometimes if they wear it one day and then they don't wear it for a few days and then they wear it again, it's probably not fitting because maybe their swelling is fluctuating. The compression garments aren't really designed to be worn when the patient is swollen. What we intend to happen is that the patient's swelling will be reduced via therapy, and then they will be fitted for a garment once the swelling is effectively reduced. And so if they are fit appropriately when the swelling is effectively reduced with a garment that is right for them, it should be comfortable, it shouldn't dig or cut their circulation off, and it should contain the swelling and not allow for that refill by the end of the day. So I think there's a lot of things to be considered, and I agree with Guenter that it depends upon how severe the swelling is. If the patient has any degree of fibrosis in their tissue, they most often will need a custom compression garment, whereas the more vascular patients who don't have significant of swelling and who don't have fibrotic tissue and who have a normally shaped limb, they can sometimes get away with that ready-to-wear garment. So it all kind of depends. I think this is where you really need to be, the patient needs to be assessed by not only a fitter at the DME company, but by the therapist, and the therapist needs to be part of picking which garment is the best for that patient. Because DME providers will have their own certified fitters, but they're not necessarily therapists. So I think getting the opinion of somebody who knows what they're talking about. And Guenter, this is probably a whole nother topic, but that kind of brings to my mind this idea of virtual appointments. So if you are, a skilled provider, and you can tell what type of garment by looking at that patient's leg, that I feel like that might be a helpful thing to be able to provide, especially for people in more rural settings that don't have access to people who know, like us, who are trained therapists. It's probably a whole nother topic, but.
And yes, we could talk for a long time, but one more point, I think that we have to recognize there are many different manufacturers who are competing with each other, and that's a good thing for us, and it's a good thing for the patient. And all of these manufacturers are eager to work with therapists in the field through FaceTime, through telephone calls and stuff like that. So if anyone is not very experienced in picking the correct garment, make contact with the manufacturer. They have people in the field, they would FaceTime with you, and then determine the appropriate way to go. And I think we need to utilize that the tragedy of our time is that no one has time, and you as a clinician need to find the time to reach out to those manufacturers, because you can expect a great deal of help from them, and that will save the patient a lot of agony and perhaps finances in purchasing the correct garment right off the bat.
No, that makes a whole lot of sense. And, and guys, I recognize this is again going to go back to the different types and all those different factors that you both had mentioned and discussed in your prior answers. But in general, what is your guys's, or how do you figure the protocol for how long they should keep their garments on?
I think that depends on the diagnosis. If you have an orthopedic patient, they would be in compression for a short period of time, and then once the swelling has resolved and they are back to, I want to say, normal function, they wouldn't have a need for continuation of the compression. Vascular patient, and Kristen alluded a lot of times the patient is a vascular patient, they have venous insufficiency, and by providing the treatment, you're not curing the venous insufficiency, it's still there, you're managing the swelling, and the patient should get used to that compression. In fact, the compression should feel so good that they want to wear it on a daily basis, take care of their garments appropriately so it fits every time they put it on, and that will most likely be for the rest of their lives. You can prevent a lot of things with compression. You can prevent discoloration in the lower extremities. You can prevent venous ulcers in the lower extremity if the patient just notices or learns about the significance of compression on a daily basis. And for patients with lymphedema, even the ones who have had surgical treatment for lymphedema, compression is a lifelong application. So they should be educated that the compression is part of their lifestyle. And if they get used to wearing the compression, and once they have the correct compression garment, they will not fight it. They will actually use it as something that feels good, that helps them to prevent swelling by the time evening comes around. And they will actually feel, in some ways, naked without the compression. That's kind of like the place where you want to get your patient to, that they are not fighting you every step of the way with the compression, but find them the garment that they can use. Because for many patients with the chronic vascular issues, venous insufficiencies, or lymphedema, it's pretty much a lifelong thing.
Yeah, and it seems like a lot of it hinges on what you both had kind of mentioned, finding that right fit garment that's right for that person. And then that seems to set a lot of the other things forward in motion on the optimal way. And, I'm just curious because something I see all the time, being in a primarily orthopedic-based setting, we think of just traditional orthopedic swelling. We think about, icing, retrograde massage, and some even use kinesio taping as well to help with that. I'm just curious because I'd love to hear kind of what your guys' thoughts are, because I know you see the things a little bit differently. What are your thoughts on using these other things like ice, retrograde massage, kinesio taping to manage just regular swelling? I know not necessarily for lymphatic, like lymphedema specifically, but even just for traditional like outpatient post-op swelling or, any kinds of swelling like that.
Well, I think there's several things here that are important, and that is, are we seeing in-session change? So any intervention that we do, we should be able to see in-session change, right? But even better yet, we should be able to see inter-session change, so in between session change. So if you are doing X, Y, and Z, you're doing your ice, your retrograde massage, your K-tape, you're doing all these fancy things, maybe e-stim, to try to treat this persistent swelling. And a perfect example of the game ready. We take a pre-game ready measurement. We take a post-game ready measurement. The joint or the limb came down 2 centimeters, and yay, and we document it in our chart. And then the patient comes back and they're just as swollen. So really, was that helpful? Maybe it was helpful, in terms of the game ready. Maybe it was helpful in terms of reducing some inflammation in the joint, especially if they're post-op. But if the swelling is outside the joint capsule and it's really not an inflammatory thing, it's more of a swelling that has come outside the joint capsule and has more of a chronic systemic component to it, not necessarily systemic, but maybe lymphatic or vascular component to it, you really, in my opinion, cannot ignore the need for compression. So I think that all of those things are nice supplements to treatment occasionally if performed correctly. But say you did all those things and the patient had a nicely fit compression garment that helped manage the swelling in between your sessions or within your session, there's going to be a much better intersession change, and the treatments that you've performed are going to be much more effective. So I think, going back to being able to do that good differential diagnostic assessment, really understanding what is the nature of the swelling. Is it just joint swelling, or is it outside the joint? And could some of these other techniques be helpful in helping it get reabsorbed? And understanding if there's any underlying components that might be contributing to that lack of resorption, asking those questions about, if they have, even if they're there for an ankle sprain and the swelling's not resolving, well, maybe they had a history of pelvic cancer with radiation a few years ago, but you wouldn't know because they forgot to put it on their history and you didn't ask. So it's just, a matter of asking good questions and selecting evidence-based treatments, but then also understanding that at some point when it comes to persistent swelling, you can't ignore the need for good fit compression and possibly MLD too.
Yeah, I mean, one is, as Kristen was alluding to, the diagnosis and then the stage of the swelling. Is it acute? Is it subacute? Is it chronic? So once you know those things, then you can tune into what you need to do in order to address the swelling most appropriately. And to me, many of those things like, ice kinesiotaping or any such thing are adjuncts to the treatment that we do. If a therapist who is not lymphedema therapy trained learns a few basic MLD skills from someone who is trained, that's great for the orthopedic population. It's great for the acute swellings. It's great for a lot of things that are not lymphedema. Once you go into the lymphedema, then therapists should seek more training, and they should build their skills to where they can serve that population. But a lot of the things that we now just talked about, the ice and the retrograde massage and the K-tape, would be an adjunct to what we do in lymphedema, and in the acute swelling, that may just be an okay thing to do.
Yeah, no, I mean, that completely makes sense. And I know diving into, you guys have both mentioned, of course, needing that higher level with, manual lymph drainage and such. But, something we haven't really talked a whole lot at this time about formally is regarding evidence being one of the three pillars of, of evidence-based practice. And, so what do we know from an evidence standpoint regarding, the ability of, manual lymph drainage to decrease swelling in those with a lymphedema component and persistent swelling? Like, what does the evidence say that we know about how effective we're doing with these folks?
I like to go first on this one because that question comes up a lot. It's up a whole lot in our field because there seems to be so little empirical evidence which proves that MLD is very beneficial for a patient. But then when we look at the clinical outcomes of our treatment, if people are committed to doing the manual lymph drainage and the compression therapy correctly on patients, the clinical outcomes and the reduction in volume and the regaining functional ability for the patient is undeniable. The problem in research with manual lymph drainage is that it would take a very large comprehensive study where, manual lymph drainage, first of all, there is very big differences from one practitioner to the next practitioner in terms of manual lymph drainage, even if they have learned it from the same training place and school. That's my experience in our training. We have, let's say, 16 to 20 people in our class. At the end, they all do well, but some do better than others. And then as they develop their skills working on patients, some therapists are really doing well, and others, they just kind of like their manual lymph drainage skills deteriorate a little bit over time. And now you're not comparing the same thing anymore. It's not a pill that you can give to the patient and then observe and 3 weeks later check that out. It would take a very comprehensive and long-term study with a lot of work involved. And we also know that just looking at our patient populations, when you do a trial on patients with lymphedema, just getting a homogeneous group together, because there's so many variables in the actual presentation of the lymphedema, the patient's age, the patient's diagnosis and comorbidities. And after all, some patients are predisposed genetically to getting lymphedema where others are not. So the empirical evidence is lacking. And what always frustrates me is when I hear about clinical trials, like there was one done in England not too long ago, last year, and that was published in a very prestigious journal in England. And the title of the article was comparing manual lymph drainage and compression with compression alone. And is there an added benefit to manual lymph drainage? Now, unfortunately, that article never really explained what the manual lymph drainage that the person was doing was really about, how long it's been. There's a big difference if you treat the patient for 20 minutes or 40 minutes. There is a big difference if you use very little pressure to the adequate pressure and such. And so there's just, in my world, too many variables to actually create a very large study that would give us the empirical evidence about manual lymph drainage being effective. And maybe with the newer indocyanine and green studies, that's a imaging technique that has just now been popular for the last few years, we will see more opportunity to do studies like that. But what is so difficult is to get those patient groups compared to each other, where clinically, I mean, I can show you results on pictures before and after, and it would just, surprise you how effective those treatments are when combined in the right way and applied on the patient in the right frequency. And I think that's a key. And many, if not all, of the research studies that compare manual lymph drainage with compression, MLD and compression versus compression alone, they have so many shortcomings that I would not pay too much attention to that.
And it seems like, I mean, correct me if I'm wrong, I'd love to hear what your guys' thoughts, but to me, it seems like that's a huge topic with so many other things, not just in the physical therapy realm too. And we're looking at researching so many different interventions to exercise, manual therapy, I mean, the list just goes on because there's so many other factors in play that it's sometimes hard to get the best accurate overall viewpoint of it. I mean, yes, there are systematic reviews, but we also have to recognize that those have limits as well, because there's only going to be using the trials that they have. So I think that there's, it's kind of a dance in motion, shall we say.
At the Institute of Clinical Excellence, we're big on the concept of and, not or. So, we have all of these clinical practice guidelines and things that help guide our decision-making process as clinicians. And yes, we want to use the evidence to do the best thing. But it doesn't necessarily always mean we have to do this or this. What if we could do this and this? What if I could treat the post-op knee patient and incorporate some of the components of swelling management that I have through my training? The result is going to be better for that patient. So kind of adopting this mentality of like, it's not a matter of doing one thing or the other thing, as it is to use our best judgment, pull the research, what the research says, but also just be open to combining some forms of treatment for optimal care for each, individualized for each patient. Maybe not every single patient needs the MLD and the bandaging, but in a lot of people, the combination of the two is going to be more beneficial than just the one. So I think just having that mentality is what I try to do, and in looking at the patient holistically and looking at the big picture and looking at how much time I have and combining all of that information with what is going to result in the optimal results for that patient.
No, I completely agree. I think that's a very, very important point, and I think that's a very valid way to say it. And that kind of gives in a little bit now more to kind of the next thought of this here is that, earlier on we had kind of talked about, so many different presentations and so many different variables to consider when treating persistent swelling. And, I guess one of the big questions I want to ask you guys is, as a lot of clinicians now probably don't work in that specialty setting so much and don't have that specialized training regarding when to refer versus when not to refer to a certified practitioner for persistent swelling. Like, what are some things that should kind of point that person to be like, you know what, you should go see this person versus, you know what, I could maybe manage this more easily myself. Like, what are your guys' 2 cents on that?
Well, I think some of the edema management skills should be taught to anyone who is doing rehabilitation, medicine. And I think that if you have a trained clinician in your area or you're working with a lymphedema certified clinician, any physical therapist, occupational therapist could pick up some skills from them to do some, I want to say, non-complicated orthopedic swelling. And with a little bit of manual lymph drainage that you learn on the side and maybe a little bit of compression skills, you can serve that population. When it comes to the comorbid patients that present with multifactorial edemas, when it comes to that venous insufficiency patient where compression is really important, when it comes to lymphedema patients, those patients should all be referred to a certified lymphedema therapist, because even though lymphedema is in the scope of anyone's practice when they become a physical therapist or occupational therapist, it should be recognized that lymphedema and those comorbid patients, or the ones even with pretty straightforward vascular disease, venous insufficiency, should be seen by someone who is trained in it, to give them the best treatment they deserve.
Yeah, I agree.
Because I know you both had kind of in the pre-show kind of had this discussion back and forth regarding what should a non-trained therapists do versus what trained therapists should do. And I think that was a really interesting discussion. And Guenter, you kind of had touched on the big take-home part of it in kind of your last statement there a little bit. And and I guess Guenter, since you've been teaching this material for such a long period of time, what do you notice that most newer trained therapists in CLT and manual lymph drainage, what do they have the most difficulty with learning and performing, especially initially and as they progress?
I think the multiple thoughts on this one. For one, I think they struggle a little bit if they go back to a setting where they don't have an established program or therapist. They lack the mentorship. They have a lot of questions, and we try to be here for them, but we're still remote. If I train someone in Pittsburgh and I'm in Colorado, I can only help them over the phone or by FaceTime or some other digital media. But I think mentorship is very important. People struggle with that a little bit if they come back and they are the only therapist in their hospital setting or private practice setting. I also think it's really important that we teach them to navigate these limitations in our healthcare system and set them off on a path to success, because oftentimes it's the insurances that limit treatments for patients, and a new therapist may give in too easily without asking for more visits. Sometimes it's the management, it's the system that they're working in that don't allow them to have the adequate time to treat patients, and oftentimes restrict them from seeing the patient often enough to be successful. So I think that these young therapists or people who are newly trained in the field of CDT, manual lymph drainage, compression, they need to be supported. And we try to be there to mentor them through their first few weeks and even months and sometimes years of clinical practice. And we need to teach them on how to best navigate those limitations in our healthcare systems. And we are doing that. We are doing that by talking them through some of the stuff that they need to share with their supervisors and management. So when they do get home, they will be able to use the skills the way they should be used on a patient that requires it, and not be discouraged by short visits or not seeing the patient often enough. I think that's really important.
Yeah, and Kristen, do you feel that, obviously you went through the program a few years back. Is that would you tend to agree with kind of those thoughts that Guenter had? And was that similar to kind of what your experience was after you went through that program?
Yeah, absolutely. I mean, I think the biggest challenges for me over the years have been, and a lot of this depends on the system that you work in, but there's a lot of of activities that are required from lymphedema therapists that are non-reimbursable but necessary tasks. And that includes getting supplies, figuring all that out. Are you going to have supplies stocked in your clinic? Are you going to special order supplies? But regardless of which way you do that, you're going to have to spend time filling out order forms, getting scripts so that they're covered, contacting the physician to sign the script and send it to the medical supply company. Measuring for the compression garments is not a reimbursable service for a PT. Calling the patient to follow up on their compression garments, or calling the manufacturing company to find out where the garments are because they were supposed to be here 2 weeks ago. There's so many side tasks that are required of lymphedema therapists that take up a lot of time if you don't have support staff that's doing that for you. And generally companies don't like that because it's not productive. Like, you're constantly busy, and when you're with a patient, you're doing a lot of manual therapy or one-on-one treatment. And then when you're not with the patient, your time is being swallowed up by all these other tasks. So it makes you kind of look unproductive on paper, which is a challenge, I think, for clinicians. And then, some companies are requiring double, triple booking, regardless of if it's a lymphedema patient. So that kind of forces the therapist to modify the treatment and potentially, like Guenter had touched on, like maybe performing a sub-maximal or subpar treatment for the patient, given the constraints of the system and the constraints of the scheduling. So those things alone are enough to make therapists not want to do this type of treatment. I don't have those constraints anymore in terms of the booking, because I only do cash-based practice with my patients now, and I have a full hour to do whatever type of treatment I feel that they need, or more time if we need it. So I am no longer constrained by that system, but those constraints are very real to a lot of the therapists that are out there trying to treat in this type of treatment.
Yeah, and not to, certainly not to step on anyone's toes, because I think people in rehab, people who do what we do, are generally very committed. But I just want to second to what Kristen was saying now. It really takes an extra level of commitment to treat patients with lymphedema. But it comes back to you, Kristen. I hope you agree that patients who are well treated for their chronic swelling, they will give so much back to you. And it's not just, financial compensation. It's just when you do the right thing by the patient, it will come back to you in so many different ways. And I found, having done the lymphedema work in so many years, I think that you get a lot of satisfaction out of the treatment. I want to add one more thing, which is really important. I think people with chronic swelling, chronic edema, people with established lymphedema that has not been treated for a period of time, we need to remember that those patients are not only physically impacted, but they are really psychologically impacted and emotionally impacted by their swelling. We talked a lot in the last hour about the physical impact of the swelling, and that swelling should be treated to increase functional ability and such. But treating patients with chronic swelling and rehabilitating them to have a much better quality of life is undescribable. Sometimes you get so much back from your patient because you're going that extra mile and you're dedicated to what you're doing, that I think it does take an extra level of dedication to be a lymphedema certified therapist and do the job well. But I would argue that it will come back to you fivefold when you do it well.
I completely agree. I think it's an extremely rewarding, it's an extremely challenging space to be in, but it's also extremely rewarding. I think, a lot of the things that we do in rehab, you can't physically see the results like right in front of your eyes. And with lymphedema treatment, you can. And that's that's very impactful for both the clinician and the patient. I think just because of the nature of it being a chronic disease that they're going to have to deal with and manage the rest of their life, then you become their resource. It's a little different than somebody that has patellofemoral pain and you fix their knee pain and they don't need you anymore. With this, it's, you're going to be their constant as long as you do right by them. Like Guenter said, you're going to be their guide throughout to navigate the management of this potentially for years to come. And that's a really neat resource to be able to be for someone.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.